vaccines, activity intolerance because these people are going to be very fatigued, and then imbalanced nutrition, less than body requirements due to a lack of appetite, and then also just, that hypoglycemia that can happen with the liver function. Okay, cirrhosis. This is a chronic liver disease that destroys structure and function of liver lobules that usually leads to death. Okay, etiology. Typically, this is caused by alcohol abuse. It is the most common type of cirrhosis. The risk relates directly to consumed alcohol over a given amount of time. So this may result from hepatitis B, C, drugs, chemicals, heart failure, or obstructed bile flow as well. But the key with cirrhosis is it's going to be a repeated issue. So the liver is incredible. The liver can regenerate, and this is just inflammation, healing, inflammation, healing, inflammation, healing over and over and over again to a point where the liver just can't do it anymore. And so typically the issue resolves with alcohol abstinence, but then when the liver begins to shrink, that's where now we've hit cirrhosis and it's irreversible. So the liver tissue itself, the lobules begin to shrink. It gets replaced by fatty connective tissue. So we'll have an enlarged, tender liver, and then people will have a right upper quadrant pain, weight loss, weakness, anorexia, bowel function will be disrupted. They'll have an increase in that portal hypertension, so that, ascites, varices, those kinds of things. And I'll keep kind of scrolling through here. Splenomegaly, upper GI bleed, lower GI bleed, hepatic encephalopathy, and then I have that astrixis there. You guys don't have to really necessarily know that. Diagnostics is going to be something we look at. LFTs, so liver function tests, CBC, looking at white count, platelets, red blood cell count, things like that. Blood chemical panels with electrolytes, looking at potassium. Potassium tends to start going up. Looking at kidney functions, albumin, other protein levels, and ammonia. Ammonia is something that the liver must clean out. And so when you have liver failure, typically those ammonia levels start going up, and the people can get very confused because of that. Coagulation studies are done because, the blood can be thinning. Diagnostics is going to be an abdominal ultrasound, liver biopsy, and then they may need an upper endoscopy if they have bleeding varices. Other treatments. So looking at diuretics, spironolactone and furosemide to help keep extra fluid off and keep the kidneys getting the fluid off the body. Laxative, I have lactulose there. That is to help directly with ammonia levels. That helps bring ammonia levels down. Does cause diarrhea. So you already have this confused person, and now they have pretty much incontinent diarrhea. Anti-infective agents, rifaximin can be used. And then some surgical things that can be done. They can do a paracentesis to remove the extra fluid from the peritoneal cavity. It typically comes back, though. It's not a long-term thing that can be done. They do have some newer things where there's like a port that they'll actually surgically place to a person's peritoneal cavity, and then they hook up special containers that will empty the fluid. But the infection risk is so great. The fluid starts accumulating faster and faster. It's not a long-term solution to this. Shunts can be placed. I've actually never seen this done before, but it was in your book, so I thought I'd put up there, where it starts directly shunting blood away from that liver in order to prevent the ascites from happening. Esophageal varices tamponade. So this is where they put a balloon essentially into the esophagus and stomach in order to put pressure on those bleeding varices, if that's what's happening. Tamponade just means to apply pressure. Sometimes you've seen it, like if people have really bad nosebleeds, they'll put, it looks like a little tampon into their nose, fill it with air or water, depending on what kind it is, in order to put pressure. Okay, priority nursing cares. Ineffective breathing pattern, because the breathing pattern will start being disrupted. Impaired skin integrity, risk for suffocation, especially with those bleeding varices. People have a tendency to vomit those up, vomit up blood, and possible aspiration, risk for bleeding, and then of course risk for acute confusion. All right, liver cancer. This isn't on the test, so I'm just going to go over this really quickly, but this is an abnormal growth of liver cells. So this risk factors, alcohol use, hepatitis B or hepatitis C. Males are 3 times more likely than females to get this. Assessment. It is pretty much the same as all the hepatitis, except we're going to have painful mass in right upper quadrant, epigastric fullness, things like that. So diagnostics, liver biopsy, MRI, ultrasound, CT, AFP may pick up serum markers of liver cancer. So that's the alpha fetoprotein. Treatment. Partial hepatectomy if metastasis has not happened yet, but as you guys know, liver is very vascular. Metastasis has almost always happened by the time a cancer is found in the liver. Liver transplant is an option, especially if metastasis hasn't happened yet. Like I said, the liver has amazing regenerative properties, so it is not uncommon to hear of parents giving their kids part of their liver, siblings giving part of their liver away. Actually a lot simpler than you might think and a lot more doable. Radiation and chemo is going to be key, and like I've said, avoiding alcohol, avoiding acetaminophen. Pain control will be priority. Pancreatitis. Okay, pancreatitis, this is inflammation of the pancreas. It can be acute or chronic. Typically, this is going to be middle life age, so like 30s, 40s, caused by gallstones and alcoholism. This is where the cells in the pancreas start to almost, they're destroyed from the very digestive enzymes they are producing because they can't get rid of it. So the 2 enzymes that they create and secrete are going to be amylase and lipase. I don't know if I have those spelled out. I do actually. They're kind of towards the bottom here because we can look at those serum levels. So here's lipase. And there's amylase. So amylase and lipase, those are the digestive enzymes. They'll actually start digesting the pancreas. There's going to typically be a sudden onset, severe epigastric and abdominal pain. It's extremely, extremely painful. These people are going to be very, very sick. It may be relieved by sitting up and leaning forward slightly. It may be pain after a fatty meal or excessive alcohol consumption. They're going to have lots of nausea and vomiting, abdominal distension, decreased bowel sounds, may have a low-grade fever, tachycardia, hypotension, elevated white blood cells, elevated serum amylase and lipase, cool, clammy skin. Chronic, they're going to have recurrent episodes of this. May increase flatulence and constipation, and stenorrhea, which is fatty, frothy smelling stools. Typically, you're going to see lots of fluctuations with blood sugars as well with pancreatitis. Key in treatment, okay? Going on to the next slide there. Key in treatment is going to be eliminating the cause. Okay, so if it's gallstones or alcoholism, then we're going to have to do something about that. And then having the person NPO. We don't want them eating anything because if they eat anything, it triggers the production of amylase and lipase. So we want their stomachs to be empty. They're typically going to be on an NG tube to keep their stomachs empty. And then they're going to be on TPN. If it's gallstones, you know, they're going to have to surgically probably remove those gallstones. And then we look at other risk factors, especially if it's a chronic pancreatitis where it kind of comes back again. They're typically at more risk for developing diabetes mellitus, malabsorption, malnutrition problems, peptic ulcer disease, pancreatic cancer, narcotic addiction, and pancreatic abscesses. Okay, priority nursing care, acute pain. Remember, I've kind of talked about this before, but morphine is ineffective to pain management with pancreatitis. It can actually make it worse, especially with, even with the gallbladder issues, morphine can aggravate that. These people are going to be usually on heavy doses of something else. And then risk for injury, risk for imbalanced nutrition, less than body requirements because they're going to be NPO. So the pastor that actually married my husband and I, his wife had pancreatitis really bad. And he tells the story. You guys, you should know this pastor. He should have been a comedian. because he's terribly funny. But anyway, he had talked about how his wife had pancreatitis and she was starving. She was like, oh my gosh, I need a cracker. Just get me a cracker. If you don't get me a cracker, I'm going to divorce you. I need a cracker. And, he's feeling really guilty. He wants to get his wife a simple cracker. And the doctor says to him, if you get her a cracker, she will die. She's going to die. And so, he talks about how hard that was, like, well, if I get my wife a cracker, she's going to die. But if I don't, she's going to divorce me, so between a rock and a hard place. She got through it. It's okay. They're still happily married. But, yeah, so NPO is going to be key. Appendicitis. This is inflammation of the appendix. So the appendix is a part of the large intestine. It is a little appendage off of there. Used to theoretically be the cecum, which some animals have. This is what allows animals like cows to get nutritional value from grass. So humans, it is non-functioning anymore. It is made of lymphatic tissue, so they know it has a role in white blood cell and immune system. They just aren't quite sure what that role is. There are correlation studies being done with like rheumatoid arthritis and that kind of thing. This is the most common reason for emergency surgery in the United States. It is most common between adolescents and young adults, males slightly more than females. Usually starts with some kind of obstruction like feces, stones, inflammation, or parasites. The appendix gets distended with fluid, very painful. The tissue becomes ischemic, so more pain. And then eventually ulceration of the appendix or perforation, so where it ruptures. And then you've got infection and feces and all this stuff going into the peritoneal cavity, which becomes an emergency situation. So there's 3 different types of appendicitis. You have simple, where it's intact, the appendix is intact, but inflamed; gangrenous, where it is becoming so stretched out and ischemic. Now we're progressing on to necrosis; and then perforated, where it has become so full of infection and pus and that kind of thing that it has ruptured. Assessment is going to be generalized upper abdominal pain, typically in the right lower quadrant as well, gradually intensifies and then localizes in the right lower quadrant. Aggravated by movement, aggravated by walking, moving, coughing, any of that. McBurney's point, that's has localized rebound tenderness. So if you apply pressure at McBurney's point and then you release, that there's going to be severe pain with that release. Extension of the right hip may intensify the pain. Very hard to diagnose in pregnant women and older adults. Low-grade fever can be associated with this. Anorexia, nausea, vomiting. And then if a perforation does happen, the person might have just, a sudden feeling of relief because, it's finally ruptured. There is just that, it gets so painful and then it's like, oh my gosh, something happened and I just feel better. But it's actually really bad. And then there could be hemorrhage with that as well, causing a rigid board-like abdomen. Diagnostics, white blood cell count is going to be very high. Ultrasound, they can usually see it right away. And then CT is also maybe used if necessary. So I'm going to scroll through those and you can pause if you need to. I'm going to keep going here. So here's a picture. You can pause and take a look at that if you want. Treatments, it's got to come out. Surgery is going to be the main option. If they've caught it early enough, they may hit it with a whole bunch of antibiotics to reduce the risk of spreading that infection and minimizing damage to that organ, but it's probably going to have to come out. And if it does resolve on its own, it almost always comes back again and is worse. Usually has to be out in 28 to 48 hours of being diagnosed. Priority nursing diagnosis and cares are going to be centralized acute pain and risk for infection. All right, I'm going to stop there and then we'll continue with burns.